Ma'am, we are live now. Should I start, ma'am? Ma'am?
Yes, we can.
Okay. Oh, very good. I, Dr. Kadri, will be moderator for this session. I welcome you to the Cynodent International and Indian Society of Dentistry this 2023. Theme of this series is Unlocking the Trends in Dentistry. For second session of today, I would like to invite Dr. Shalu Rai ma'am. She is the principal at Agartala Government Dental College. Topic for this session is current insights into oral cancer diagnostic. I would like ma'am to please start with this session.
Good evening, everyone. I wish you a very happy Diwali. So the topic that I've chosen today is the current insight into the oral cancer diagnostic. This is the college, that is the Government Dental College Nagpur, from where I've graduated and post-graduated from, and from where I have just learned the basic of dentistry, and I have grown as an academician. Oral health is a reflection of the physiological, social, and psychological factors that are essential to our quality of life. Cancer poses a significant and pressing public health challenge in India, and it is a top priority within the mandate of the ICMR. According to estimate from the Global Cancer Observatory, for the year 2020, there were 19.3 million new cases of cancer worldwide, with India ranking third in incidence after China and USA. So Globocon projections indicate that India one day in the year 2040 will witness a substantial increase in the cancer case, going up to 57.5%. So the main role of WHO is that it is working on reducing the premature mortality from a non-communicable diseases, including cancer, by 1/3 through prevention and treatment. This is the main goal of the cancer intervention. Hence, the topic for today is the current insight into the cancer diagnostic. We have to intervene the cancer in its pre-malignant conditions, in its pre-malignant lesion, so that we are able to give a good life to the patient and an increased span of life. So we talk about oral cancer, which is the 10th most common cause of death. Cancer of oral cavity and oropharynx contribute 3% of annually diagnosed cancer in US. Oral cancer represents more than 5% of the total body cancer, whereas the ratio is 4:2, with male being predominantly affected. But then it's more affected by the habit. India has 33% of the total burden of oral cancer globally. And when you see the scenario, it's pan-India. You have the north, the central, the east, the northeast, west, and south. And the prevalence and the epidemiology of cancer is different depending on the various different types of habits, the eating habits of these tobacco-associated products. So most patients are often asymptomatic at the time of diagnosis. We have to create an awareness as an oral physician. Some patients do not seek care until pain, persistent ulceration, unexplained bleeding, or an oral or neck mass is discovered, at which time the disease is very well advanced. So the 5 years survival following the diagnosis of oral malignancy can be as low as 15 to 50%, as most cancer are advanced and they're associated with lymphatic spread at the time of discovery. And majority of the cases of oral cancers are squamous cell carcinoma, with buccal mucosa having the most common site, about 32%, followed by tongue, lower lip, and palate. So why we need to detect the cancer at its early stage? Why we want to intercept these oral lesions at its pre-malignant uh, region is because we want to have an effect on the main effect on the morbidity and mortality. The oral cavity is subjected to a routine screening and clinical examination for malignant changes, and most easily detected and diagnosed in the early stage, leading to most effective management. However, despite the easy accessibility of oral cavity for examination, oral cancer still remains a lethal disease. So the benefit of the early detection is that it can be treated or removed earlier. It gives less stress mentally, physically, financially to the patient and to his family members. There are better chances of survival, and you can successfully manage these cases of cancer even post operatively. So I would say prevention is better than cure. An ounce of prevention is worth a pound of cure. So now let's talk about the prevention. We will go step by procedures are there. You have a primary prevention, you have secondary prevention, you have tertiary prevention. Primary prevention is the prevention in the change of your lifestyle, which is associated with oral cancer. You know, the stress of our life, the smoking, alcohol consumption, neglecting the nutrition of the food greatly affects the lesion and its progression. Secondary prevention mainly targets on the early detection with subsequent intervention. This is what I'll be talking about, that we as an oral physician are supposed to detect the lesion at its smallest size, and then we will be able to give a better life to the patient, and that is possible only by various ways of examinations and screening. So the examination would be the intraoral examination, which cannot be substituted by any form of investigation or any other form of screening. Visual examination and the extraoral examinations are there. Tertiary prevention is a form of chemoprevention. That is, you are supposed to, the relapse of the disease after therapy or minimize the therapy-related morbidity. So there are two approaches when you call about for the early detection of dysplasia of the cancer. One is the screening program, and one is the specific diagnostic tools which are available. So oral cancer is almost always preceded by a visible precancerous lesion or a dysplasia. According to American Dental Association, identifying the white and red spots that show dysplasia and removing them before they become cancer has proved to be one of the most effective methods for reducing the incidence and mortality of the cancer. Early treatment prevents the malignant transformation. It also improves the lifestyle modification by reducing the risk factor, and thus, prevent the regression of the precancerous lesion. So what is precancerous lesion? Morphologically altered tissue in which the cancer is more likely to occur than its apparently normal counterpart. Whereas the precancerous condition in its turn is a generalized state associated with significantly increased risk of cancer. So if you read literature, you will find various terminology like oral precancerous lesion, precancerous condition, and potentially malignant disorders. So these are the type of commonly lesions which you encounter in the oral cavity, which should, ring an alarm as an oral physician when you're examining the teeth. So just examining the teeth will not be sufficient as a dentist or as a dental surgeon, I would say. You should look into all the aspect when we are thinking about the habit of the history, when you're taking the clinical, the history of the patient and doing the clinical examination. You're supposed to look for any kind of red or white lesions, which could be either in the form of flat, speckled, or nodular. This is the non-homogeneous leukoplakia. This will always, the patient will always have a history of tobacco consumption. These are the various type that you see, homogeneous and non-homogeneous. Proliferative type, or it could be a flat type. Nicotinic stomatitis, in case of a reverse smoking, the lesions are seen on the palate as a homogeneous red area on the palate with an inflamed opening of the minor salivary gland. Early lesion appears slightly wrinkling that disappears when the tissues are stretched. So, you just give the diagnosis as a pre-leukoplakic patch or a tobacco pouch keratosis. But then the patient needs, you are supposed to make the patient aware of the lesion that is present here and the consequences of the lesion which might be there after a few years if he doesn't stop with the habit. Other lesion may appear as hyperkeratotic granular patch, whereas the advanced lesion will be seen as a thickened zone of grayish-white mucosa with well-developed folds and fissures. So precancerous condition, as I told you, increases the risk of the cancer, oral submucous fibrosis, lichen planners, especially some types of lichen planners has a more tendency for malignant transformation. Oral submucous fibrosis, because of the habit, the patient may have a prodromal symptoms or a late symptoms. Generally, the patient reports in the late symptoms. The early symptoms could be just a vesiculation or an ulceration. The vesicles, just a pinpoint vesicles might appear in the oral cavity, which might burst and leave a small ulcer. And then it could just resolve. And the patients would, just avoid it or just ignore those kind of lesion. But then gradually the patient might, with the habit, the patient will progress into trismus, difficulty in tongue protrusion, swallowing, blanching of the mucosa is there, marble-like appearance of buccal mucosa, fibrotic changes in the soft palate, hockey stick uvula is there. There is thickening and shortening of the tonsils, depapillation of the tongue, loss of elasticity of floor of the mouth, and the gingiva, if involved, will become fibrotic, inelastic, and blanched out. So these are various stages actually of oral submucous fibrosis, and if you see the literature, there are various classification depending upon the mouth opening, depending upon the movement of the tongue, then depending upon the effect on the buccal mucosa, involvement of the labial mucosa, or as the lesion progresses posteriorly, there is an involvement of the pterygomandibular raphe, and then the uvula, the soft palate. So there are various classification, and then the intervention of these lesions are dependent upon the severity of the lesion. So these are the different features that you see in the oral cavity. Sometimes the patient might just have, a slight buccal blanching of the mucosa, but when you see the lesion, the soft palate also might be blanched out. The uvula might give you a shrunken appearance. So these all are the cases which are in the pre-malignant condition and will slowly progress into a cancer stage if the intervention is not done at this stage, at an early stage. Lichen planners, there are various types of lichen planners. You have the 7 Ps, you have the atrophic, papular, erosive, plaque type, bullous, reticular. And different types of lichen planners have different malignant potential changes. The erosive lichen planners have more tendency for turning into a malignancy. So any red and white lesion that you see, not associated with the tobacco habits goes more in favor of lichen planners. Now, the word potentially malignant disorders, earlier described as pre-malignant lesion and condition, has now been listed under one umbrella, that is oral potentially malignant disorder. So these are the lesions as I already discussed. I'm discussing just the most important one. And it could be a lesion which various forms of signs and symptoms which should give you a red alert when you are talking to the patient, when you're doing the clinical examination, or when you're taking the history of the patient. It could be just a non-traumatic ulcer which is present, the traumatic ulcer which is present on the tongue, which is non-healing ulcer. And any ulcer which does not heal within 4 to 6 weeks should raise a suspicious give you a suspicious, effect. A lump, red and white patch, numbness on the tongue, chronic pain, chronic sore throat, difficulty in the movement of the jaw or the tongue, some form of displacement or the mobility of the teeth, weight loss is there, or you have any form of voice change effect on the oropharyngeal region, difficulty in chewing, swallowing, lump, swelling on the neck. So the various diagnostic tools and the which are used today, which I'll be talking about, is uh, there are actually various classification, and currently available many diagnostic tests which are there, which are used in clinical practice and in many of the oral medicine department, as well as many clinicians are also using it, would be either in the form of vital dye staining, oral cytology, optical imaging. And new methods under development for clinical application is DNA biomarkers, mRNA biomarkers, protein biomarkers. And the latest one are the AI-based system and lab on chip. So when we call about the vital dye staining, there are various types, and these are the various types of classification. Whereas in vital dye staining, you will have toluidine blue staining, you will have Lugol's iodine staining, you will have acetic acid. Whereas in biopsy, you have incisional biopsy, brush biopsy, FNSE, excisional biopsy, cytology. Then lab diagnostic tools could be either form of the positron emission tomography, ultrasound, MRI, nuclear imaging. And then we will be talking about veloscopes, that is autofluorescence method, and chemofluorescence, which is VisiLight. So all the accuracy of these diagnostic tests is based on their specificity, sensitivity, positive predicted value, and negative predicted value. Just remember one thing, these are all based on the literature and the research that you actually study in the journal. And these terminology as specificity, sensitivity, you will always be coming across when you're talking and comparing the two methods. So the most important is the clinical method, I would say, for the early detection of the cancer. Nothing can replace a conventional oral examination. And hence, physiological nature of the buccal mucosa or the tongue should be known to a dentist. Its variation should be known to the dentist, and then only he'll be able to differentiate between the normal variations and the pathological one. So conventional oral examination is the prime thing. Then comes these stains that I told you. And then the photodynamic diagnosis, which is veloscope, and the other test and the AI methods. This is another type of classification. So conventional oral examination, the specificity of this examination goes to up to 98%. So the palpation and the examination of the buccal mucosa, lip, the gingiva, the hard palate, soft palate, tonsillar area, vestibule, tongue, the lateral border of the tongue, the ventral surface of the tongue should be done properly the patient, the dentist can evaluate the tongue, by holding the tongue at its tip, asking the patient to move the tongue on the left buccal mucosa, right buccal mucosa. Then the floor of the mouth can be evaluated by just putting the tongue on the palate. So these are the various things which can greatly affect the prognosis, the mortality, the morbidity of the patient, and the treatment protocol. Thorough examination and knowledge of the oral manifestation of the cancer may reveal finding that will help in the diagnosis and treatment. So early detection is the prime requisite. Detect early, you will be able to treat early. So let's talk about the most commonly that we use as a pre-screening test. And these are, in every department of oral medicine, I would say, whenever we are encountering any kind of lesion which gives you a suspicious nature, we go for toluidine blue staining or a Lugol's iodine or an acetic acid staining. This is a chair-side investigation which is easily available and does not require much of an investment in your lab or in your clinic. So you have a topical application here, less false positive. Test rate is there, stains only the dysplastic tissue and aids in the diagnosis of potentially malignant lesion. So the lesion which is stained, you are able to actually take only that lesion as your biopsy site, and the histopathology diagnosis will be very much, positive. So these are various the technique that is generally used: rinse mouth twice with water, 1% acetic acid application, drying, then applying 1% toluidine blue and rinsing it with 1% acetic acid, and then rinse with water. So acidophilic metachromatic dye has the staining property of the metachromasia, and due to the presence of repeated phosphate group in the nucleic acid, it takes up this dye. So the blue stain is lost after application of 1% acetic acid. Then it is a benign lesion. Then effect on the benign lesion, it defined intake of dye at the margins. Whereas in case of dysplasia or malignancy, there is diffuse marginal pattern. So this is how the lesion will appear after the intake of the this dye, and accordingly you can decide the site of your biopsy. Positive staining, if the mucosa is stained positive, repeat the procedure in 1 to 2 weeks. Biopsy of all site is advised which stains positive on 2 successive site. So if there is, dark blue, that means it is positive. Go for the motivation of the patient, go for counseling of the patient, motivate the patient to stop the habit. And then after 2 weeks, again call the patient. If it is there, again, you are supposed to do the biopsy and take this lesion seriously. Specific area for biopsy, you will be able to, decide. Cheap and non-invasive, disposable, high sensitivity for carcinoma. The disadvantage is that the color of the dye remains in the mouth for about 4 to 6 hours. And it might give sometimes a false positive reaction because of the inflammatory and ulcerative condition. Lugol's iodine staining, the specificity is 60%, sensitivity is 87.5%. And Lugol's iodine, can also be used prior to biopsy and resection, and it's useful in determination of the best incision area. You are supposed to clean the lesion with a cotton tip soaked with 10% H2O2. That is, it will remove all the saliva, food, or tissue remains. Cleaning of the lesion with water jet. Application of this Lugol's iodine. It is available, a ready-made form with a cotton tip for 30 seconds. And then photography of the lesion can be done. Based on the binding of the iodine to glycogen granules in the cytoplasm, it results in black-brown tissue color. Iodine is glycophilic, and so the application of Lugol's iodine solution results in the uptake of the iodine in normal glycogen-containing epithelium, stains it brown or black. So the area of dysplasia and invasive cancer do not take up iodine as they lack the glycogen, and they will appear mustard yellow or saffron colored. So we saw it in the toluidine blue, it will take those blue color, okay, because dysplastic cells have more metachromatic effect and more DNA replication is there. Whereas Lugol's iodine here, the dysplastic areas will show you a poorly stained or unstained region. Whereas a normal epithelium will stain brown, dark brown. This is also a method which can be used, acetic acid test. Sensitivity is very high in this and specificity is high as you compare it to Lugol's and this thing, toluidine blue. Clinical examination using 5% acetic acid. This reacts better with dysplastic or malignant cells. Lower sensitivity, but it has a higher specificity compared to toluidine blue. Photograph of the lesion can be done. Gauze piece soaked with 5%. Apply it for the about 60 seconds and then photograph the lesion again. Positive finding, the lesion changes the color to opaque white, and negative finding means there is no change in the color. We talk about VisiLight. These are actually the type of equipments which are showing a very good result. The sensitivity is 100%, specificity is 14%. Non-toxic chemoluminescent light that illuminates in the mouth of normal tissue, they glow differently compared to normal tissue. Make them more aceto-white. So this actually comes in a full, package of the rinse, the capsule. The rinse consists of 1% acetic acid. The capsule is the thermoluminescent light stick. And the technique is that you are supposed to ask the patient to rinse the mouth with plain water. Application of 1% acetic acid is done. Then this capsule is held and the outer flexible capsule of the light stick is bent, thus breaking the inner fragile glass vial. And the light stick is then shaken vigorously to mix the content. And then the VisiLight plus capsule is activated and placed on the retractor. Abnormal mucosa will show some amount of reflection of the light. So this is how the VisiLight mechanism is there. And abnormal epithelial cells will have show some amount of disruption and thus causing the loss of fluorescence. Whereas normal tissue will produce fluorescence and appear as an apple green glow. So this is the image that I can show you here, which is the lesion at the buccal mucosa under the incandescent light, whereas with the VisiLight, it appears aceto-white. Optical methods for early diagnosis, photodiagnosis can be used. This is a veloscope method, which has a sensitivity of about 97 to 100%, specificity is 94 to 100%. The use of autofluorescence in the diagnostic tool for cancer detection was first described in 1924. It's a non-invasive method, useful for optimum location of biopsy. The device is used under a dimmed room light with protective eyewear worn by the patient throughout the procedure. And then with a specific device has a visible light in 430 nanometer wavelength to cause fluorescence excitation of certain compounds in the mucosa. And the normal unaltered mucosa emits a pale green autofluorescence when viewed under a selective narrowband filter, whereas a dysplastic tissue loses the fluorescence emission power due to disruption of the distribution of the fluorochromes, and they will appear more darker in color. So dysplastic area, there will be complete loss of normal tissue fluorescence, was rated as a malignant or having dysplasia, and thus the biopsy site can be planned. This shows the region of loss of fluorescence in the where there is leukoplakia. It's painless with no stains and rinses required, improves the distinction between normal and abnormal tissue. There is a visual and digital soft tissue examination has to be done before you go for this technique. Useful benefit in the determination of surgical border and post-surgical evaluation. It covers large surface area, so small lesion can also be, identified. But then a heat from prolonged and close tissue examination may lead to discomfort of the patient. Lack of methodologically sound clinical trials are there, and insufficient use of histologic and molecular mapping are the major disadvantage of this technique. We talk about the histopathological examination, which is the gold standard examination for the diagnosis of the pre-malignant lesion and the malignant lesions, having specificity of 94% and sensitivity of 92%. So biopsy is a very advantageous chair-side investigation, and there are various types of biopsy that can be conducted depending upon the size of the lesion, the site of the lesion, and this also determines the prognosis and type of treatment required. So any undiagnosed clinical condition, detection of malignancy, fixed lymph node enlargement, absent local factors, as you might not know why there is ulceration or there is bleeding, evaluation of non-neoplastic lesions, post-operative screening for granuloma cyst, rapidly growing lesions, and root resorptions with loosening can give you an indication for the biopsy. It is useful for the diagnosis, for grading of tumor, metastatic lesion, evaluation of recurrence, any management assessment for benign and malignant lesions. So you have the excisional biopsy, you have incisional biopsy, you have brush biopsy, you have the cyto smear or the cytobiopsy. Excisional biopsy, total excision of the small lesion for microscopic examination is called excisional biopsy. Therapeutic and diagnostic procedure it can be used for. Whenever you see that the lesion is small, even cutting the tissue half would not, give a proper diagnosis histopathologically. So such lesion you can completely remove from the oral cavity in the form of excising it in toto. So a small lesion, usually done in case of a lesion smaller than 1 centimeter, sessile or pedunculated, freely movable tissues. Like you can see a ear, it could be either a traumatic fibroma or a lipoma or, a pyogenic granuloma, which could be pedunculated, sessile, ossifying, a small ossifying fibroma. All these lesions can be completely excised. Anesthetize the lesion, with 2% anesthetic solution, dissect the tissue, submerge it in 10% formalin, and then suture the site, send it for histopathological examination. Excisional biopsy, it's a most common type is the wedge type of, incision that you give. I will not talk in detail about this. Incisional biopsy can be performed by removing a wedge shape in specimen of the pathological tissue along with the surrounding normal zone. It is very important when you do the incisional biopsy that you are, or any form of biopsy, you are supposed to remove the surrounding normal tissues also. Large lesion where you cannot remove in toto, go for incisional biopsy. Select the site, do an give a local anesthesia, infiltrate it, give a wedge shape lesion incision with a scalpel, remove that thing, put it in 10% formalin, and give a suture. You can also perform it with a punch. OSMF can be biopsied with the help of a punch biopsy, which are available in different sizes. And it gives you the epithelium and the connective tissue, sufficient amount of depth, sufficient amount of tissues. Size of the tissue is mandatory for the complete histopathological examination. This will not require any form of suturing. It will heal automatically. As far as punch biopsy is concerned, as I told you, there are disposable punch biopsy available in the market, or you can also get a stainless steel one which can be autoclaved properly and then can be used with successive patient. Exfoliative cytology, Surface of the lesion is either wiped with some sponge material or scraped to make a smear. Microscopic examination of this cell shed from an epithelium might be visible here. It has a sensitivity about 90 to 100% and specificity to up to 94%. It is mainly important for periodic review or in case of a debilitated patient, or for a screening purpose. There are various classifications that are available for the to examine and to give a histopathological diagnosis as far as cytosmears are concerned. And this will, in this various classes which are there for the interpretation, will help you to decide whether they are atypical cells, whether they come into intermediate state, whether are suggestive of cancer or positive for cancer. Or you need to repeat and go for a biopsy. When it comes to class 4, when it is suggestive of cancer, then in that case, biopsy is mandatory. Main advantage is that it is painless. It's a very good method for a screening procedure, low cost, bloodless procedure, time saving, rapid diagnosis, safe procedure as complications are rare, and valuable for screening lesion whose gross appearance is such that biopsy is not warranted. But the disadvantage is that it is not applicable for a firm to hard tumors. False negative results due to inadequate sampling is the major disadvantage. And sometimes non-assessment can happen because of some of the specimen cannot be assessed due to its poor cellularity. FNSE, it's a fine needle aspiration cytology having a specificity and sensitivity of about 85 to 94 percentage respectively. Microscopic examination of an aspirate obtained by inserting a fine needle into the lesion. It's painless and safe procedure for rapid diagnosis, but the lesion has to be either soft, and cystic, mainly indicated for salivary gland pathology, suspicious lymph node, metastatic lesion, or replacement for extensive biopsy. So this is the procedure, the kind of needle that you're supposed to use, the syringe that you're supposed to use, how you're supposed to, the depth that you need to, instill into the lesion is a prime factor for FNSE procedure. Brush biopsy sensitivity is up to 100%, specificity is also 29 to 100%, depending upon from where you are taking. And, it majorly implies the clinical examination process, and it decides from where the lesion has been taken. Oral CDX brush system, that is the brush biopsy, but then you can just collect the epithelial sample in this case from the mucosal lesion. It's beneficial for patient who cannot revisit. And if you think that the lesion is suspicious, go for a brush biopsy. Negative result indicates there is no epithelial abnormality, and positive results indicate there is an epithelial dysplasia, some form of cellular evidence is there. Some metastatic, the cells dysplasias are there, and then it has to be referred to a scalpel biopsy. Various molecular methods are there, which we can talk about. Depending upon the, which is not actually, we would say, about the chairside investigation. It is DNA content depends on the chromosome number. So flow cytometer are there, and various devices which are used for DNA analysis. But then the disadvantage is that it only scans with with severe dysplasia of detectable oral malignancy can be detected. Various tumor markers are there, which are very useful. Biochemical substances released by the cancer cells will help you in knowing which type of cancer is there and what is the prognosis. It can be seen in the blood circulation, body cavity fluids, in the saliva, cell membrane, and cell cytoplasm. For example, in cases of leukoplakia, tumor markers like PCNA are generally found, which can be a valuable predicting lesion behavior. Then microsatellite markers are there. This is a very sensitive method, studying the clonal changes in the tumors and pre-malignant lesion. Requires very small quantity of DNA. In oral pre-malignant lesion, there is a loss of heterozygosity is seen. Various salivary gland biomarkers are there. Like I said, there is a oral squamous cells marker. There is a salivary biomarkers there, which can be used to determine the prognosis of the lesion. There are non-invasive approach procedures. Immunofluorescence method, there are various direct method, there is indirect method, there is sandwich technique, FITC methods are there, which are useful. Fluorescent dyes are used for this methods in this technique. I will not describe the direct fluorescence or the method, the techniques which are applicable, but this is also one of the methods which can be used for the early detection of precancerous lesions. Positron emission tomography is also used in defining mainly the occult metastasis. So the accuracy is up to greater than 90% for locating this recurrent tumor or the occult metastasis. As I told you, some chips are also used nowadays. These are the fast cytology test, microfluidics technology. This lab on chips effectively reveals the cancerous and precancerous condition in a very short duration. So I would say that oral cancer is a growing concern with its catastrophic worldwide, including India, Pakistan, globally affecting our system. Unfortunately, with all the advancement in the understanding of the disease process and recognizing the associated risk factor, the 5-year survival rate remains only 50%. So the patient survival rate can be affected by its early detection, diagnosis, and treatment of pre-malignant lesion is to prevent their transformation to oral squamous cell carcinoma. So early diagnosis is mandatory and it can happen only with the dentist. A referral without delay to any oral medicine specialist or an oral physician would be undertaken, which will save the life of the patient as well as effect on the patient's lifespan and the quality of life of the patient as well as his family. So the WHO has noticed that this has recognized the prevention and early diagnosis and recognition as a chief objective to limit the cancerous condition. It is acknowledged that both preventive and screening of oral cancers are important, thus improving the quality of life, but also increasing the 5-year survival rate. This is just a summary. So you have to make a choice. Life gives us an opportunity for growth, disguised as challenging circumstances. Be the change. Thank you.
Thank you so much, ma'am, for the informative session. Ma'am, we had a few questions from the viewers, but you have already answered all of them. But I have one more question for you. Should I ask, ma'am?
Yes. Go ahead, please.
Ma'am, which is the best chair-side diagnostic method for oral cancer, which can be easily done by the clinician or the students?
The diagnosis, as far as diagnosis is concerned, oral examination is very important. You should be able to examine the buccal mucosa, the labial mucosa, the tongue, the palate, the hard palate, the soft palate, gingiva. You cannot, compensate as far as the oral examination is concerned. But as far as the investigation is concerned, when you think that this lesion is suspicious, then a best chair-side investigation is go for a pre-cancerous screening, do a toluidine blue staining, and immediately go for an incisional biopsy. That is the best method which you can, increase your doubt. You can actually solve your doubt and you can increase the patient survival.
Thank you so much, ma'am, for the answer. I would like to thank the founder and CEO of Cynodent Dr. Anmol Bagaria, ma'am, and co-director of Cynodent Dr. Ashish Chandra sir for organizing this webinar series for us. And also thanks to all the participants who joined us today. And I kindly request to all the viewers, please like, share, and subscribe our YouTube channel for getting daily updates and webinars. Thank you so much, ma'am, for the wonderful session.
Thank you.
Thank you,
Thank you,
ma'am.
Cynodent. Thank you very much.